first speaker is Elad from Boston is going to be the first one talking about.
Thank you, Dr. Natali. You know, the initial idea, I was asked to speak about the physiological relationship between sleep apnea and atrial fibrillation, and I'll try to cover that. But I think at 7 o'clock in the morning, most of you are less interested in how the cytokines induce sleep apnea and what's the relationship, but more about what do I really do with this information to my patient. Can we change the prognosis of patients with atrial fibrillation and sleep apnea? Is there anything we can do? And the answer is yes, and I'm just going to go through some introductory slides and just tell you what do we do in Boston at Beth Israel to try to help these patients and improve our outcome of AF ablation. So, you know, I think it's like an epidemic now. There isn't even one single week that you don't see a paper about the relationship between atrial fibrillation and sleep apnea. You have over 200 publications just in the last 5 years, but really every week there is a new publication. And I think the real question is this link real, or it's just a trend that we see, and it's a fashionable correlation? So let's review some of this data. So the first study that really looked into the association between sleep apnea and atrial fibrillation was the Sleep Heart Health Study. It was a multi-center longitudinal cross-sectional study that included over 6,000 patients, and it really aimed to assess the burden of all arrhythmias, not only fibrillation, PVCs, VTs, and so forth, in patients with sleep apnea. They compared 228 individuals with moderate to severe sleep apnea to 338 individuals with either no sleep apnea or mild sleep apnea. And what they found was pretty striking was that the prevalence of AF alone was 5-fold higher in patients with sleep apnea. Really significant, and a very good study. A year later, another study came out from Olmsted County, and it's called the Olmsted County Sleep Study Registry. Also a large study. They looked into over 3,500 individuals without atrial fibrillation that underwent initial assessment for sleep apnea. Now, obviously, this population was saturated with positive results because they were like screened with other clinical tools, and 75% of these patients had a positive study. And the aim of this study was to follow them and see what's the incidence of a new atrial fibrillation in a cohort that has sleep apnea. And the follow-up duration was close to 5 years, and this is what they found. That sleep apnea was an independent predictor of AF with a hazard ratio of 2.18. Okay, so I think several questions that interest us as clinicians that treat patients with atrial fibrillation is what is the prevalence of sleep apnea in our patient population, in patients with atrial fibrillation? The answer is that, you know, it's really hard to tell, but when you look on the literature, and especially when you start looking now in new data that is coming, as we are more aware and we screen these patients more rigorously, the real life number that we get is around 50 to 75%. So it's really high. But again, if you look on in all studies, you can see that it's anywhere between 10 to 75%. Is diagnosis of sleep apnea in patients with atrial fibrillation is important. It will be important for several reasons. One, because we can change the prognosis of atrial fibrillation in this patient, but more than that, we're not only treating arrhythmias, we're treating patients. Diagnosing sleep apnea, treating sleep apnea, not only improve the outcome of AFib ablation or any management of atrial fibrillation strategies, it also improves the well-being of the patient. It reduces the risk for stroke, it reduces blood pressure. So we're doing a good thing to the patient when we screen him for sleep apnea. And I'll go into this in a second. So let's just spend 2 slides and discuss what is the mechanistic relationship between sleep apnea and atrial fibrillation, and I'll divide it into 2. 2 in the sense that what happens if we acutely occlude the glottis and induce a negative intrathoracic pressure that stretches the heart, what that does for induction of fibrillation, what happens when these episodes repeating themselves again and again and again, multiple times a night for a long time. And this is a beautiful study that was done in pigs, and what they did, they tried to mimic the effect of acute episodes of sleep apnea and tested the effect of inducibility of atrial fibrillation and on other parameters, in this case, atrial ERP. And what they did, they intubated pigs and they used a device that can mimic the effect of inspiratory effort against a closed glottis. And when they did that, so in this case, they reduced the pressure by 100 millimeter of mercury. So you have negative intrathoracic pressure that results in stretch of the thin-walled atria, and that led to decrease in atrial ERP, so the refractory period of the atria decreased. And when you try to induce atrial fibrillation in pigs, the initiation of atrial fibrillation was really easy to induce. When you just kept these pigs intubated, but you did not induce sleep apnea, atrial ERP did not change, and it was extremely hard to induce atrial fibrillation. The conclusion from this study was that negative intrathoracic pressure by itself promote induction of atrial fibrillation, and that has been repeated by several other studies in human. Actually, in clinical lab, if you are doing atrial fibrillation ablation, or if you have patient with AF under general anesthesia, you can just stop the breathing. If you stop their breathing and you wait for the saturation to go down, sometimes it takes a minute and a half. In half of these patients, we've done it like in 36 patients, in half of these patients, you'll have initiation of atrial fibrillation. It will not happen in patients that don't have history of atrial fibrillation. So that's very interesting from a mechanistic standpoint. I love this paper from Stan Natal from Canada, and he took it to a much higher level of science, trying to illustrate what's the effect, or investigate what's the effect of chronic repetitive occlusions of the upper glottis on the structure of the atria that lead to atrial fibrillation. And what he found was that sleep apnea not only results in atrial fibrillation via induction of negative intrathoracic pressure. What it does, it really causes fibrosis and slow conduction in both the right and left atria. And you can see here conduction velocities in 3 different groups, and the group that sleep apnea was induced for several weeks. He kept these animals chronically, and you can see that the conduction velocities are lower. He went on and he questioned why conduction velocities are slower, and he looked on gap junctions, and you can see immunofluorescence of connexin 43. These are the gap junctions in the heart, and you can see that you see many more green staining on the sham group or the open airway group, but when you go to the sleep apnea group, you can see fibrosis with no gap junction, explaining why conduction velocities are going to be slower. And when conduction velocities are slower, that can set the stage for reentry to occur. And this illustration put everything together very, very nicely. If we imagine that each of these blue lines is a single episode of atrial fibrillation, many of those are required over a long time to eventually reach the threshold to develop clinical atrial fibrillation. And while the initial episodes are due to stretch of the atria, later on, the substrate of the atria changes in a non-reversible way. And the interesting part is that it does not affect the atria first. It affects the ventricle first. It causes hypertrophy, diastolic dysfunction, and via activation of molecular pathway, mostly the MAP kinase pathway, fibrosis and scarring of the atria is induced, and it's at the stage for atrial fibrillation. So, what is the relevance to our practice? does OSA affect the response to our therapies, either ablative therapies or medical therapies? Can we as EP interfere the process? And I'll show some data that we have now, and I'm sure that Dr. Chinitz that had a wonderful meta-analysis study that was published just recently is going to go over this in much more detail. In our study, we looked on 426 patients that came for initial PVI. There are some screening, obviously, some patients were excluded, but overall we identified 62 patients with confirmed overnight sleep study that showed sleep apnea, at least moderate degree of sleep apnea. It just turned out that 32 of them were treated with CPAP and were compliant with CPAP, while the other 30 had sleep apnea of the same severity but did not use CPAP. We included two control groups. One control group is patients that have atrial fibrillation, same duration of disease, but no sleep apnea. And the most interesting group is actually the patient that have atrial fibrillation, sleep apnea, but did not undergo ablation procedure. The groups were matched in all variables. And this is what we found, and I summarize it in 3 bullets, but they really tell the whole story, and it's reproducible with other studies that came either before or later. So freedom from atrial fibrillation following ablation was higher in the CPAP user group compared to the CPAP non-user groups. You can say, okay, but look on the number, 71.9% versus 36.7%. It's like amazing. It's almost like a placebo, like this is almost no response. 36.7, it's like really low response, and most of these patients had paroxysmal AF. Patients with treated sleep apnea had similar outcome to patients that did not have sleep apnea at all. It almost makes you wonder, like, should I even consider taking a patient to the lab without knowing if he has sleep apnea or not? And this is, I think, the most important bullet here. Patients with untreated sleep apnea who underwent PVI had an outcome that was similar to patients who did not undergo PVI alone. When we saw this data, we said it's unbelievable. How come, like, we go around the veins, we isolate the veins, and then, like, after a year, they come back and exactly the same outcome of patients that did not have any ablation procedure? How can we look on our patients and just say, you know what, we're just electrophysiologists. We really don't care about you as a human being, about your other diseases. We're just going to try and address your arrhythmia. We can't do it any longer. And this is the Kaplan-Meier curve showing that the blue and red line are patients with, either no sleep apnea at all or sleep apnea treated with CPAP. Completely same outcome. And below here, worse outcome of patients that are not compliant or not using CPAP at all, and they are compared to patients that had no ablation whatsoever. This is the table from Dr. Chinitz, recent meta-analysis that he will probably show, but overall you can see that this data that we presented wasn't different from other studies, including the first study by Dr. Natali and subsequent studies later on in the last couple of years. So I'll tell you what do we do with this data. And this is what we do at Beth Israel in Boston. So diagnosis of sleep apnea in patients with AF, we think it's important. All cardiovascular patients are screened for presence of sleep breathing disorders. This is in implantation like in the last few months. Treatment of sleep apnea is integrated into AF practice. Establishment of care with a sleep specialist. It's very hard to do that, multidisciplinary work. It sounds really great on slides. It's very hard to implement it actually in the hospital because of various reasons. We identified one person that just happened to be enthusiastic, and he wanted to do that among 7 other sleep specialists that absolutely had no interest. We found him, he found us, we collaborate really nicely. We initiate CPAP therapy. One of the questions is, when should you initiate CPAP therapy? ideally the day after you being diagnosed with sleep apnea. Practically, it's impossible. It will take time. So sometimes it starts before we do the ablation, sometimes 3 or 4 months later. This is reality. We are monitoring the response and the compliance. It's very easy to do it with the new CPAP machines. You know exactly how much the patient is using this. We can actually repeat the sleep test following initiation of sleep therapy to see what's the effect of CPAP on a sleeping disorder. And individual tailored therapy for management of AF, evaluation of a patient-specific triggers, and underlying substrate. And I'll show you data in this regard. This is, the study that we are doing, but overall, this is the protocol. Patient with AF being referred for a PVI. From a administrative standpoint, we send a request to the scheduling office. It became standard that this patient gets some kind of imaging, either a CT or an MRI. At the same time, they get a sleep test. Actually, to get a sleep test, it's easier than to get the MRI, because as you will see outside, and maybe I can show you later in a slide, the watchpad device is very small. It's like a halter. We have boxes that are labeled with return label as well. We send it to the patient. The patient uses it overnight, like a halter monitor, or send it back to us. By the time the patient arrives to the lab, we know if he has sleep apnea or not, and we know what the degree of sleep apnea that he have. And this is in fact what we do in the lab, and I'll show you why in a second. You are familiar with voltage maps. Until recently, we didn't do any voltage map for patients with either paroxysmal or persistent AF. We will isolate the veins. It's an anatomical procedure, and that's it. We realize that should not be the case any longer. We have a paper that is coming showing that the majority of triggers are still from the pulmonary veins, but 30% of patients with sleep apnea have triggers that are not coming from the pulmonary veins. And this needs to be assessed. Now, this is an example on the left of a patient that has paroxysmal atrial fibrillation with no sleep apnea, completely normal bipolar voltage map. Right atrium, left atrium look completely normal. Patients at the same age with severe sleep apnea, you have bilateral decreased voltage that is pretty actually site-specific. The decreased voltage will be on the anterior septum, around the SVC. So on the right atrium, around the SVC, close to the IVC crista area, low crista IVC, and on the septum, anterior septum, close to the mitral annulus on the left atrium. This is another example. And when you isolate this patient's vein and you try to look for non-PV triggers, this is what you do. In this case, we just give isoprel and we wait. We just keep them like at pacing at 600 milliseconds. You can see first the fractionation here. So the signals are abnormal. This is not during AF. This is just during pacing. And you can see also that this is like an isochromal map. You can see the late activation in the septum, again, setting the stage for reentry to occur. And an AF begins in 25% of these patients just with isoprel with no pacing. So where do we go from here? All patients with AF should be routinely screened for the presence of sleep apnea. A multidisciplinary approach incorporating a sleep specialist and or institutional sleep medicine clinic. Patients with sleep apnea may require a different ablation strategy targeting non-PV triggers. More data prospectively is required, and this is what we're doing now. It's a prospective study that will be associated with 3-year follow-up. Therapy with CPAP should be recommended to all patients with at least moderate sleep apnea and AF. And this is I'm not sure that I have the latest iteration of the device, but this is how the watch path looks like. Very easy to use. It comes with instruction. The patient goes to sleep with this. Next morning, send it back to us. Patients with at least mild sleep apnea are referred to a sleep specialist for initiation of CPAP therapy. So the way that it goes, we get a device back. We're busy. We don't have time to do all of this. So what we do, we just download. The device actually gives you a report, and it tells you the patient, have you downloaded it to a USB, to a computer? My administrative assistant does it. If it's positive, she sends the document and the detail to the sleep specialist, which within the same day arrange an appointment for him to be seen. In patients with sleep apnea, the ablation strategy includes targeting of all non-PV triggers, and a combined follow-up approach is needed. So when we see this patient for follow-up now, there is a nurse practitioner that sees the patients like the first month after the procedure. The next door is the sleep specialist seeing the patients. Thank you very much.
So Elad, beside the impact on AFib, I think it's important that people hear this about the hard data, mounting data that sleep apnea, severe sleep apnea, especially if untreated, can affect even survival.
Right.
And that's very important. You know, with AFib, we think we are affecting mortality, but we're really treating immediate quality of life. But that's a much more important negative. So you know, make some comment about that, the mortality.
Yeah, absolutely. There is data about mortality. There's data about stroke. You know, we can't ignore sleep apnea any longer. You know, the other point is that the fatigue, because many of these patients that we see, especially with persistent atrial fibrillation, they complain of fatigue and lack of energy. You know, I start to wonder, seriously, how much is it due to the atrial fibrillation and how much is due to the sleep apnea? I don't think it matters. I think if you treat the sleep apnea and you treat the atrial fibrillation and they feel better, great. But you know, all of the consideration aside from controlling the rhythm itself are important. And survival and stroke are, I think, the most compelling reasons.
So the other things, we used to give everybody, I don't know if the people here are familiar, to everybody that walk into the office, there's something called the Berlin questionnaire, which is a sort of an easy tool to screen patient. In the reality, we use the Berlin questionnaire because if you think about the standard sleep study, it's not easy to send the patient to do a standard sleep study. So the advantage of this system is the easy in implementation in making the diagnosis. Once the diagnosis is done, then you convince the patient, you know, you have a problem, you need to address it. But to convince a patient to do your conventional sleep study, go into a facility, sleep there, it's a total nightmare. And sometimes he was mentioning about a few weeks, or it takes, you know, months before you actually, and you have to push the patient. Have you done it? Have you done it? Have you done it? So this is something that is so easy to discuss with the patient and is easy to implement. So I think this is one of the advantages. Would you? Yeah.
I completely echo Andres' sentiment and observation in that, because every single time you talk to a patient about their sleep apnea, the first preliminary answer is that they don't have it. I mean, denial is like the first thing that they come across. And obviously, everybody has their own reasons to give. I mean, I can't tolerate the mask, or I think objective evidence in the form of a questionnaire, I think, goes a long way in making that point in a bigger way.
Okay, so thank you, Elad.